Hello, my name is Paul Friedman. I'm chair of the Department of Cardiovascular Medicine at Mayo Clinic, and I'm delighted to be joined by my colleague, Dr. Abhi Prasad, who is a professor of medicine and directs our interventional cardiology program. Abhi, thank you for joining me.
It's my pleasure, Paul. Thank you for inviting me.
So today I'd like to talk about chronic total occlusions. Um, Kind of an interesting area, especially in light of recent clinical trials. So maybe we should start with some basics, like how common are they and how are they defined?
Sure, Paul. The basics are very important. So the definition is any occlusion that's been present for more than 3 months. And you could imagine that's very hard for something that you cannot determine definitely. It's a sort of somewhat of an arbitrary definition. So in practice, we define it by the appearance of the CTO when angiograms are done. They have a distinct appearance, not always easy to tell, but generally together with the patient's symptom duration and the angiographic evidence. But for the purpose of strict definitions, at least 3 months of occlusion. And how common are they? Again, there's obviously a referral bias because we define the prevalence by angiograms. We don't obviously do routine CTOs on a population level. But if you go by cath lab angiograms, they're present in about 10 to 15% of patients. And again, we're talking about vessels where it might be reasonable to intervene upon. If you include the wider tree and branch vessels, then they're more common than that.
So not rare. And then
No,
the clinical presentation would be persistent angina.
that's the typical patient we see, at least in the clinic. Of course, like any other coronary disease, it could be silent, but the ones we see in clinic are patients who have been treated on one or two antianginals who are then referred for consideration for revascularization.
So then who's the ideal patient in whom you would do a CTO PCI?
Sure, Paul. I think this is a really important area because we want to, as for any revascularization patient, we want to pick the right patient. The typical patient is a patient who's been on at least one or two antianginals and remains symptomatic. And of course, as you know, that could be quite subjective, and we do take patient preferences into account. But a symptomatic patient on medical therapy who has reasonably good quality vessels, and that again is something that we have to gauge. And what do we mean by a good vessel? A large caliber vessel, good distal vessel that when we connect the two pieces, you are going to get good flow, supplying at least a moderate to large area of myocardium. Do we stray away from some of these sort of criteria? Yes, we do, but we try to stick to them. And then comorbidities, as with any area of our practice, increasingly complex patients, post-CABG, elderly, and we have to be careful. So we do take comorbidities into account. But the first two criteria are really where we base our decision making.
So before we get into maybe the management for the non-interventionalists, the things to look for, in my mind's eye, in a way, it's like doing surgery without doing surgery. You have a vessel with a proximal end and a distal end and a complete occlusion between them. How do you do this magic trick of connecting a vessel without opening up the chest?
Absolutely. It's just funny you say that like magic, because I do tell patients that because sometimes they underestimate the complexity of the case. And I say that it's literally magic. If we invented PCI today, it would be one of the most amazing things. And yet it's been around for 50 years. So how do we do it? The technique fundamentally is the same as non-CTO PCI. Involves the same catheters, guides, wires, but the differences come in the actual specific types of wires. So we have dedicated CTO wires that are capable of penetrating calcium or fibrous occlusions. Then we have dedicated microcatheters, very low profile, hydrophilic coated. Some of them are actually torqueable, so you can screw them through the occlusion. So that's kind of the standard equipment. And then we have dedicated techniques, these dissection-based techniques, which have come from the periphery, which is something that, when you learn PCI, you never want to do is to dissect a vessel. But when you get into CTO PCI, we do need sometimes to dissect around the occlusion, or sometimes we get into a dissection plane and we just have to get back into the lumen. So dissection-based techniques are integral to CTO PCI, and that has also some dedicated wires and concepts that are used. So you dissect past the occlusion, and when you get to the distal beyond the occlusion, you re-enter into the true lumen. And then there are the retrograde-based techniques where you come from the contralateral vessel through collaterals and enter the CTO distally and then make your path backwards, so to speak. So we've combined all of them. In the past, the approach was to do a wire-based technique first, and if you failed, you bring the patient back another day and do the more complex procedures. We nowadays come in with our strategy lined up, and we iteratively kind of work through an algorithm and use a variety of these techniques. And sometimes we go back to the first technique that failed and so on. And the hope is then to provide a successful procedure in one setting.
Absolutely remarkable, actually, when you think about it, right? A closed artery inside a beating heart being opened while someone is lying there sedated, but not even under general anesthesia. Which practices in CTO PCI maximize success, minimize risk? And what do you quote a patient for a typical success rate? And I realize it probably varies a lot based on anatomy, but what kind of range, for those of us who'd be referring somebody, should they expect in terms of risk, and what kinds of risk of death, myocardial infarction, or other complications might a patient expect?
Sure. So the success we quote these days is at least 80% for an average patient. Now, as you suggested, there is a range, and sometimes it can be as low as 50% for the most complex calcific, long lesions with poor distal vessels. But on average, we'd like to pick patients where we can give them 70 to 80%, ideally 80%, maybe even higher success rate. And in terms of complications, their complication rates have been coming down all the time. And with contemporary practices, I would say that the average complication rate is around 2% for major adverse events. To put that into some perspective, the non-CTO PCI, we typically quote 1% or less complications rate for an elective case. So we're talking about 2 to 3 times the risk. And that's really been a real advancement, because in the early days of CTO PCI, and when I say early, in the contemporary world of CTO PCI, the complication rates were up to 5%. So we've really brought them down a long way.
Now, for the physician considering referring someone to CTO, do you like to see viability testing ahead of time? Is there other preparation or assessment that should be done so that you're well prepared to proceed?
Yeah, I think that can be, viability, as in other areas of our practice, has never been, clearly demonstrated to be beneficial to be used routinely. So the way we do it is it's selectively. So for the average CTO patient, we don't do viability testing. But if there is a patient who has symptoms that are borderline questionable and significant regional wall motion abnormality in the distribution of the CTO vessel, I think it's reasonable to get viability if you have high quality imaging, which we're very lucky to have. So our go-to is typically PET imaging, because you can do both ischemia and viability testing in a single test, and getting a sense of the burden of ischemia and the burden of non-viable tissue does help us make decisions, particularly if a case on clinical criteria is a little borderline for offering PCI. I think that's where it helps me.
Now, what about the patient who's had an acute MI and you're interested in complete revascularization, and you have some CTOs on non-culprit vessels? What's your strategy there? What's your thinking? When do you leave them alone, and when do you say, no, we should go after this?
Yeah, Paul, that's a very important question, because, the practice in ACS has been moving towards complete revascularization. A large number of STEMI trials have suggested that we should aim for complete revascularization. More recently, in the non-STEMI arena, the trials are leaning towards complete revascularization. And so, this is a very important question. In the CTO world, if you have a non-culprit CTO, the clinical trial, and there's been one trial only done that showed no benefit in terms of LV remodeling based on MRI imaging and even on clinical endpoints. It was a small trial, so obviously not powered for clinical endpoints, but definitely the only trial that's ever been done in that arena has not shown benefit. So I think we should be very careful for the CTO non-culprit lesion. I think I would treat it as any other patient. So if the patient becomes asymptomatic after an MI, and I think there needs to be a very careful decision-making based on viability, ischemia, symptoms, and then decide individually, independent of whether this is a non-culprit or not. I hope that answers your question. It's a slightly complicated area, because we would love to revascularize it, but I think the data suggests it doesn't help.
Got it. Yeah. And there is always some risk, even if it's small. And you mentioned, of course, ischemia on testing. Is there an ischemic burden that you'd say, oh, this is enough that we really should do this versus it's small? And it's probably hard to quantify, but what are your thoughts there?
Yeah, so at least at Mayo, we don't quantify burden in terms of percentage. But although certain centers do report percent of myocardium that's ischemic or infarcted, so it's not something that's part of our thinking. I mean, obviously, we look at the number of segments as a kind of rough estimate of the same thing. But I think the most important thing is there ischemia or not? How large is it in terms of number of segments? And then symptoms really drive our decision making predominantly.
Sure. No, that makes sense. Is there any new clinical trial data for CTO PCI?
Yes, so our practice does not have a lot of trials. I mean, you can count them literally on a hand, the number of randomized trials supporting practice of CTO. Yeah. But at ACC recently, there was the Orbita CTO trial, interesting trial of just 50 patients, sham controlled. Again, so not a lot of sham controlled PCI trials that have been done, but this Orbita group have done a few, and randomized patients to either a sham procedure. So they came to the cath lab, and it was after the angiogram that the randomization occurred. Mm. And then the patients actually were taken off their medical therapy coming in. And it was to no therapy versus CTO PCI. And there was clear benefit in symptom relief. So I think at least we can address that issue. Does PCI do anything? It absolutely relieves angina, and it supports a large body of evidence in the CTO world that PCI, if anything it does, is relieve symptoms. And this trial showed that it was better than a sham control procedure. So I think, and this together with at least one other randomized trial that also showed improvement in symptoms, I think we have very good evidence for doing PCI for symptom relief.
So it works better than nothing, but does it work better than medical therapy?
Good question. So yes, so there is that one other trial called a EuroCTO trial that was done a number of years ago, about 100, 150 patients randomized to optimal medical therapy versus optimal medical therapy plus PCI. And even in that, the Seattle Angina Score indices were in favor of PCI. So I think even with medical therapy on board, PCI performs better.
So it remains a good option for symptomatic patients. And then lastly, I've been struck with the ability to do these complex procedures so effectively. And whenever we have complex procedures, people are always coming up with new ways, new tools, new devices. Tell us about any breakthroughs in this space that you think may change the landscape to make them even more successful, safer, faster, or otherwise improve the process.
Yeah, Paul, I've been amazed, the iterative improvements in the wires, the microcatheters, and so on. The one tool that we're looking forward to bringing on board is a forward treating shockwave intravascular lithotripsy catheter. So we have the standard IVLs, which give axial delivery of the shock waves, but a new catheter that's been developed for peripheral interventions, but now will be available soon for our coronary use. The emitter is just 3 millimeters from the tip, and so the shock wave is delivered in an antegrade fashion. So we should be able to modify the proximal caps. So for uncrossable or a lesion that we think right up front is very calcified, it may be a new technique. So we're looking forward to getting our hands on that.
Sounds like just a tiny touch of dynamite to break through into that.
Absolutely. Conceptually, we've been there before where things seem very simple. Yeah. We hope that, based on how IVL has performed so far in our standard practice, I'm very hopeful that this will make a difference.
No, it has been for intravascular fibrosis very successful in coronaries, in veins with device extraction. So fingers crossed that this will offer one more tool to even further enhance the capabilities. Well, Abhi, thank you. Fascinating space, remarkable work, and thank you for updating all of us on it.
It's my pleasure, Paul. Thank you.
At Mayo Clinic, learning fuels world-class care. I'm Dr. Peter Noseworthy, Chair of the Division of Cardiac Electrophysiology. I hope you enjoyed today's episode, and I want to let you know about the full courses that we have available. Head over to cveducation.mayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses. Join the thousands of clinicians who have already turned their curiosity into expertise at cveducation.mayo.edu.